We're going to talk about anticoagulation, and then Dr. Brown's talking about special populations. So for those of you that are on for the first time, EMS Challenge, we started this about 7-8 years ago to get more physician-led Con Ed for the region. We're pushing it out twice a month now, the second and fourth Wednesday. The fourth Wednesday, the Alabama Fire College sponsors us, and we are able to do skill labs with their staff and equipment. We should be in Opelika the fourth Wednesday of May. So if you're in that area, please come out and see us. We'll have live and on-lab lectures from 9 to 11. And then from noonish to 3-ish, we're going to have a skills lab. We'll do surgical airways. We'll do some ultrasound training. We'll do some mega codes and then some airway training as well. So good stuff. I won't read this to you today, but this is the purpose behind EMS Challenge. For your certificate, you can use the chat box. Chief will put a link in there. You can always email us at alabamaemschallenge.com as well. Give us a few days to get the certificate back to you. Obviously, if you watch this, participate, if you do half of the Con Ed we provide every 2 years, you get enough for national registry. So the purpose of this is to give you the physician-led Con Ed and also give your EMS officers a chance to do more station-based training, skill labs, and take some of the burden off of you guys. This past Monday, we had a presentation here at Centerpoint where we recognized crews. They had, over the course of the past 1.5 to 2 years, we've had 12 patients survive out of hospital cardiac arrest, and those 12 left the hospital neurologically intact, walking, going back to a regular life again. I know there are more of those saved in the region. We should recognize those more often, but fantastic work. Protocols are in full swing as of the 29th. Remember, if you don't have a medical director, it's probably time to get one. There's a lot of lax in these protocols, especially for the paramedic. So make sure you're doing the right thing for your patients. If you know what you're doing, you can really make a positive impact and help people. If you don't, you can hurt somebody. So make sure you know what you're doing. Remember, as the advanced EMT, you can give epi and cardiac arrest now, the 1 to 10,000. Make sure we're using the right dose for that. We talked about Opelika. And then the first week of June is Alabama ACEP. It's 12 states holding a physician EM conference down in Sandestin, and EMS folks are welcome and encouraged to attend that as well. So I'll talk about anticoagulants. If you look at this graph, and I'm not a graph person, this is probably one of 2 graphs you'll ever see me show up. But if you look at the numbers between 2017 and 2025, the use of anticoagulation is just skyrocketing. It's one of the most lucrative drugs out there. I would say that, and maybe some of the new COVID stuff we got coming out. But anticoagulation is out there. We're going to see a lot of patients that are using this. The reasons we use this is for AFib, for DVTs, for PEs, for strokes, people with vascular stents, and then anybody in the hospital. If you've ever been a patient in the hospital, you're anticoagulated. You get a heparin, a Lovenox. So a lot of reasons to do that. A lot of our patient population takes these medications, and the fact that people are on this medication kind of dictates the way we manage them as well. So here's the exciting stuff. Okay, well, Chief Ward's always cross-eyed, to be honest with you, but we'll leave it at that. So this is the clotting pathway, and I remember learning this in med school, and I remember having inappropriate thoughts as we learned this as well. But in short, just for review, the 2 pathways, the intrinsic and extrinsic, we're kind of going away from that with some of the literature, but either way, when a cell is damaged, the surface of a blood vessel is damaged, you get these proteins. Factor 12 gets activated to 12A, activated, which then affects 11, which affects 9, which combines with an activated 8 to make 10 get activated, which then makes 2 get activated by 10 into 2 activated. At that point, it activates 1 to 2, and you get cross-linked fibrin strands, and a clot is formed. How'd you like that one, Doc? I know, that's good. I know, perfect sense. If a cell, if the vessel is damaged, like cut, jabbed, shot, 7 gets activated, which then activates 8 and works on 10 to activate it. It makes the same pathway, all right? And all at the same time, you got other proteins in there, protein C, thrombomodulin, and all those things go to make a big clot, right? In addition, you have calcium swimming around in the vessels, right? And calcium has to be there to make all this work. Without calcium, there's no energy, right? In addition to that, there's also other proteins. Hey, come on in, exciting stuff. You're missing out. Yeah, man, this is great. There'll be a quiz at the end, gentlemen, so get ready, okay? Sure. All right. In addition to the calcium that's swimming around, right, there's also other proteins, things we don't even know what they are out there swimming around. But the goal of this is to make a clot so you don't bleed to death, all right? And that's the purpose of this clotting factor, right? This clotting cascade, all right? We got that? You good? Okay. The doctor in the house says yes. Very clear as mud, right? There's also some hemophilias, all right, out there that you may have studied about in paramedic school, A and B, and it kind of shows you what they are. A is factor 8 versus B is factor 9, and you can kind of see where those will play in there. All right, so one more time, I'm gonna let y'all walk me through this. If you would walk me through this, sir. Right, yeah, it kind of blows your head, doesn't it? Right, how'd you like to put that in there? That's pretty good. That's good, yeah. Very confusing. So definitely don't try to memorize this, but this kind of gives you the idea that there's a lot of things that go into play when we talk about clotting factors and how to prevent clots or how to make clots. So there are different drugs out there we can use to jack up this process. And you're going to see if we can jack it up this way at thrombin, and I can sell you a drug, I can make money off of this, right? And then another company come and jack up factor 7 and sell you a drug. So a lot of ways to do that. So a lot of medications out there that mess up the clotting cascade. So let's go back and look at why people take these medicines, right? To stop the clotting, all right? So AFib. AFib is probably the most common dysrhythmia you ever see in your care of your patients. The older we get, if we have any pulmonary problems, hypertension, if we have exposure to maybe COVID and have long COVID, anything that causes increased pulmonary pressures is going to cause the atrium to get enlarged. When the atrium is getting enlarged, it screws up the conduction system of that and you get AFib. AFib causes two problems. One, decreased cardiac output. So they get a decrease in the blood supply they can pump out to the body under activity. The other thing it does is it churns the blood and the blood gets stuck in the atriums. And there's a high risk for that blood to turn into a clot. And then it go into the ventricle and push out, and that clot go to the lungs and cause a PE, or go out the left side of the heart and cause a stroke. So AFib, people with AFib are higher risk for having strokes, PEs, and other issues, right? That clot will break free. It follows the big vessels, and when it gets to a vessel that's too small that it can't pass through, it occludes it, and that causes the problem. And that's why we have a stroke system. And if someone has signs of a stroke, unilateral weakness, speech disturbances, vision changes, right? If we can get them within 4.5 hours to a hospital, we can give them medication to break up that clot and open up that vessel, and their strokes will get better in theory. AFib can also throw clots that don't go to the brain, they go to other parts of the body, like the bowel. You can get ischemic bowel, which is bad because we don't recognize that as readily. And now someone has a ischemic bowel, the bowel starts to die, the bowel ruptures, they get peritonitis. There's no medicine to reverse that. They have surgery to fix it, and those guys have a bad outcome. So AFib, if you're throwing clots, can be very dangerous. So there's a benefit to thinning the blood on people with AFib because now they have a less chance of having a stroke or ischemic bowel or ischemic fingers or other things that can hurt people. All right. People also higher risk for having DVTs need anticoagulation. So a blood clot is where you have the venous system, right? The veins don't have muscles in them. So the only way blood returns to the venous system is by the skeletal muscles that contract around it in the legs, all right? Or just by the hydrostatic pressure from the arteries as the blood is pushed through the body. So people who have peripheral edema, people with heart failure, people who have leg swelling, the blood will pool in their legs, it will sit there. As it sits there, it gets stagnant and forms a clot. All right. Most DVTs don't hurt people just from the clot itself. You can get some that can completely occlude the vessel. And if that happens, then you get increased third spacing, you get compartment syndrome. People can actually lose their legs from that, right? Most folks don't get it that bad. The problem with most DVTs is now you got this blood clot in this vein. It gets so big that now it breaks into pieces, floats upstream, and goes into the lungs, goes into the right atrium, the right ventricle, and gets into the lungs. And now you have a blood clot in the lungs called a PE, and the people can't breathe, bad things happen, you can die from that. So the purpose of anticoagulation, somebody with a DVT, deep vein thrombosis, is really to prevent a PE. Blood thinners do not dissolve these clots. Blood thinners make these clots not get bigger. The body will come back at some point, and like we've talked about with the TXA, the body will come back and break these clots down, all right? And then the blood thinner we give them make it where the clots don't rebuild. But the blood thinners don't actually break the clot down. They prevent them from getting worse. Everybody still alive? Everybody sign off online? Cool. I'm getting cross-eyed from a guy in a white shirt here, so good. All right, good. Other reason we give people anticoagulation is people who have stents in them. So if you were to have a STEMI and you have a big clot in your coronary vessel, they go in with a wire, they balloon that open, they compress the clot, then they put wires, stent mesh, kind of to bridge this open so blood continues to flow. The problem is that's going to scratch, irritate the inside of the lumen of that vessel. So it's going to activate that intrinsic pathway I showed you a few minutes ago for blood clots. So blood clots will form around the stent and reocclude this, and you defeated the whole purpose of going in there and putting the stent anyway. So we give them blood thinners, anticoagulation medicines. So even though the body starts that clotting cascade, it can't make clots. The blood is thin and it floats through. Now, 6, 8, 12 weeks later, the body is used to this stent. We can get them off those blood thinners. It's no longer irritating the vessel. It's kind of grown into it. So it's not a foreign invader anymore. And they can do fine without anticoagulation. But if you put a stent in someone's coronary artery, they got to be anticoagulated at least for several weeks to months. Otherwise, it does no good. They're going to reocclude. That's why there's some patients we cannot give stents, coronary stents to. So if I had somebody who had just had a hemorrhagic stroke, bleeding in the brain, and by some mishap, they have a heart attack. Now they got a big stent, they got a big clot in their heart. We can't go in and put a stent in there because we have to anticoagulate them or we're going to make them worse. But we can't anticoagulate them because the blood in their brain would get worse. All right. If we have somebody who's mentally challenged or has an underlying mental disorder and cannot take medications by mouth and they have a big heart attack, sometimes all we can do is go in and balloon them out, try to make the vessel bigger and not put a stent because we know if we send them home, they can't take their medications and they're a reclot because of the stent. Same thing if you have somebody who has bad vascular disease, we put a stent in the femoral artery to open up the blood supply. They got to be anticoagulated for a while, or you stimulate that intrinsic pathway, they have clots. So there are different names for these medications. NOACs is for non-vitamin K antagonist, right? Anticoagulants. You can call them DOACs for direct thrombin inhibitors, a lot of things out there. We also have heparin. We'll talk about how that works in a minute. And then the vitamin K antagonist was the first drug out there, which is kind of like rat poison, Coumadin, warfarin, right? Great stuff. And there are others out there too that aren't really used so much for outpatient therapy, things we use in the cath lab or the surgeons use when they do vascular surgery. So back to our pathway, we talked about the intrinsic pathway that's jacked up by stents and so forth. Extrinsic pathway by injury or trauma, all right? We talked about the fact that you got to have calcium and other proteins floating around. You also have to have platelets. Without platelets, none of this pathway starts. Platelets are teed in around factor 10. Without platelets, none of that works, right? So you have to get an understanding. That's the way I think about that sometimes too. All right. So platelet activation. So something will stimulate a platelet to pop out proteins on its cell wall so it can join together. And we talk about this a lot when we talk about aspirin use and STEMIs. But without this platelet activation, you get no clots. Okay. So when I think about platelet activation, I think about there's something that stimulates the platelet to realize there's been a tissue damage, either intrinsic or extrinsic. The platelet sends out spike proteins so they can stick together and make clots. So platelets are activated, they come together, other proteins come together, and now we have a clot. So if we can stop platelet activation, we can do a lot of work in thinning the blood. That's why aspirin is really important in STEMI care. And again, aspirin works around the 10 and activated 10A. Semi-inappropriate humor, a lot of medicines out there. Maybe somebody will wake up. No, nobody even smiles. Good. Thank you very much. You ever watch those commercials late at night? Some of the side effects, it's ridiculous, man. All right, moving on. Yeah, really, who's going to take that crap? No pun intended. So platelet activation, aspirin, we talk about this a lot. It's an indirect activator. So aspirin jacks up thromboxane, and thromboxane makes it where the protein spike that comes out of the aspirin does not work. So this portion of the platelet will not combine with another platelet. So it kind of free floats on down the vessels. There are other drugs out there, Plavix, Brilinta. These are on P2Y adapters. Just like this, if you take this medication, it makes those proteins, the way that platelets attach to each other, non-functional. Integralin is a GP2B and 3A receptor, and this is what we use in cath ab. So if somebody's having a big freaking STEMI, we may start an infusion of this medication so that platelets cannot adhere to that new stent we just put in there. There are other medicines out there. Platelets are very important in this clotting cascade. So if we can block this by a couple of pathways, we can make someone really have thin blood, not be as responsive to having a worsening STEMI or an issue with that. So that's why we use aspirin in the hospital. If somebody comes in having a STEMI, we see the STEMI, they got clinically, they fit the bill, they got aspirin by EMS. We're going to give them one of these two drugs. So we give them what we call dual antiplatelet medications. So the platelets will not stick together. And then sometimes in the cath lab, the cardiologist will add one more of these medicines. And if we can stop the platelets from starting the process of clotting, we can keep that clot from getting bigger, and we can keep them from getting the clot around that new stent we just put in them. There are other drugs out there, Eliquis, apixaban. It works on factor 10. So it's a 10A inhibitor. So it inhibits this right here. So there's no factor 2 to 3 to make the clot. Xarelto is another one you probably send your patients on. Same thing, works on the same portion. It's a different drug, right? So you got two companies making money off of that. Pradaxa is another one. Pradaxa is a direct thrombin inhibitor. It inhibits thrombin, so therefore you can't make these fibrin strands and make a clot. All right. First case. This is a guy that's been on a road trip. He's got a DVT, so he's on Eliquis. And remember, the purpose of the Eliquis with the DVT is not to make the DVT better, but make it where he doesn't get a pulmonary embolism, right? So he's on Eliquis, had a few beers, slipped on the elevator or escalator, went home, now confused, and his wife calls you, okay? So what's he at risk for if he's on Eliquis now? That was the beer. That would lead to divorce. Eliquis would not lead to divorce. Help me, Lord. Yeah. So remember, Eliquis jacks up factor 10, so it thins the blood. You can't make clots. So these guys are really high risk for head injuries, right? Intracranial hemorrhages. That's why in our system in Birmingham or the state, if someone has a fall from standing and they're on a blood thinner, we'll put them in the trauma system, right? And the reason is they're high risk for having head injuries, okay? This is a big subdural. This is blood under the dura. The white stuff is blood. If you think about it, the head's going that way, the feet are going this way. This should be over here. So big midline shift, right? Folks that are older, folks that drink alcohol a lot, folks with underlying mental disease where you get brain atrophy, the brain will shrink. And then these vessels that bridge between the dura get pulled real tight. And then small falls with people that are anticoagulated lead to subdurals. All right, a normal person could fall, maybe get a little bit of a bruise right there, not a big deal. But if you're on that Eliquis or Xarelto, you can't clot. So that blood gets bigger and bigger and bigger. You get blood in the brain. If we don't go in and remove that blood, you have issues with that. People have bad outcomes. When you think about head injuries, the three types that I kind of think about, really four, but there's the epidural, and this is the blood that's usually arterial from usually a skull fracture, and you get bleeding above that dura. so it's nice and pretty on the CT scan. This person should have been in the OR probably 10 minutes ago. Epidurals are bad, arterial. The subdural we kind of talked about. And then there's intracerebral, where you have damage to the brain tissue itself. That's usually from a hemorrhagic stroke or penetrating injury. Then you can get a subarachnoid hemorrhage as well, which is usually from trauma or an aneurysm. So how do we manage these in the hospital? There's a medicine they made to fix this. So obviously, if you make one medicine to thin your blood, we have another medicine we can sell you to unthin your blood, right? American healthcare. This is called Indexa or Index 10A, whatever you want to call it. But this is artificial activated factor 10. So we can take this medicine, give it to them, and it restores that 10A factor in the blood. So that even though Xarelto or Eliquis is jacked up the natural 10A, we give you new 10A and you can actually clot. And we can't make that subdural get smaller, but we can make it not get bigger. And if we have to take you to the operating room, take your skull off and evacuate that blood, we can make it where you don't bleed out because we have completely reversed or fix that problem. Okay, but if we do this and he's still got a DVT, what's the problem? He's still got a risk that DVT breaks off and goes to his lungs. But risk to benefit, you can't live with blood in your head. All right, we're kind of driving down the road, going from one ditch to the other with this. All right. The problem is this stuff is pretty expensive, man. Dr. Brown, you remember what the cost is? I remember looking it up at one point. I want to say it was like 40K is what they charge the hospital. So no telling what is charged to the patient, right? Lots of money, all right? There's another product out there called PCC. This is actually was made to reverse Coumadin, but 4-factor PCC is great. It's Kcentra. It has artificial factor 2, 7, 9, and 10. So we can load the body up with these factors and you can start clotting again. Works pretty good. This stuff is actually cheaper now. It used to be pretty expensive. It's probably $4,000 to $6,000 cost to the hospital. There are actually some EMS agencies in other states that are carrying this on their super trucks or their critical care because so many people are on blood thinners, right? So you got a guy that's on Eliquis that falls, smacks his head. He's now altered, unresponsive. You know he's probably got blood in his head. You're going to fix that right now because blood in the brain is bad. The 3-factor is not available in the U.S. anymore. Phebia is more expensive. It contains all these factors, but it carries factor 7 is also activated. It means it really just works a little bit faster. Most places I work with use Kcentra. There's a few places that I've given Phebia before. Questions in the world out there yet, Chief? Or did everybody sign off?
I got a question for you.
Uh-oh.
You mentioned brain atrophy.
Yes.
From alcohol.
Not on alcohol itself, on the clotting factors, but folks who do have chronic alcoholism, it affects your liver, and your liver makes proteins that kind of float around all those factors we talked about, and will jack up and make your blood thin and make you bleed easier. So chronic alcoholics with liver disease, cirrhotics, they have a high risk for bleeding, yes. And anything that you do or take that destroys the brain makes it shrink up. So if you're a chronic alcoholic, if you're using meth or coke, other drugs, things like that that destroy the brain, you're going to have an increased risk of subdurals from falls.
So the other one is, so if you have a patient who's regularly taking one of the anticoagulants, what's the, does that protect them from ischemic stroke completely?
No, there's nothing that protects you completely, but it decreases the risk of having clots get bigger, right? Now they can have atherosclerotic disease, they can have plaques and things like that on the vessels that slowly close off and cause problems, and it doesn't prevent any problems. But what it does do is it makes it where even though the vessels are narrow, the platelets won't activate and make a clot in that narrowing because they're on that medication.
You say that those two are the most common we see in the public realm?
Yeah, there's still a lot of people on Coumadin or warfarin because it's just really cheap. The difference is if you take Xarelto or Eliquis, you don't check blood levels. You just take your pill once a day and you call it a win. If you're on Coumadin, your dietary intake can change the levels of how thin your blood is. And so you got to check your blood levels once a week for a while until you get stabilized, and then once a month. And it's really variable based upon your diet. And don't ask me which part of the diet, because I don't know that. I could fake it, but no. Greens, that's right, yes. Alcohol will make it. All right, so this kind of shows you where the 4-factor works. It gives you factors 2, 7, 9, and 10. So factor 2, factor 7, factor 10, and then factor 9, wherever 9 went. I don't even see it now. I'm losing it. There you go. Very good. You are paying very good. You'll get an A. Yeah. The numbers? Yeah, I don't know, sir. Yes, sir. Welcome to American healthcare once again. Yeah. Yep. And they're actually going away from, we used to name these things, but now I think in academia, we don't say prothrombin, we just say factor 2, but it's is what it is. But this kind of shows you how this stuff works, right? So if I got somebody that's already on Xarelto, their factor 10 is messed up, I can give them this, and I give them new factor 10, right? All right. Now they may need a second dose later because they've already taken this medicine that's going to mess up their factor 10. So when I give them this new factor 10, if it stays in there long enough, it may become inactivated because of the medicine they already took. So we can dose this based upon when they took their last medication or how things are going. All right, second case. 74-year-old male, abdominal pain, he's got blood in the toilet. Obviously, we're going to do our ABCs. We're getting the history. He's alert, pale, his belly's a little bit tender. We're checking the radial pulse. Is his skin warm and dry? He says he has a history of COPD, hypertension. He's pre-diabetic. We're all pre-diabetic, right? He's got a history of AFib. He takes a blue pill, a white pill, the round pill. So what things matter for this guy, right? So we talked about this a lot with the STMs, the stuff that matters. So COPD, dude's got a history of COPD. That makes me think he probably has AFib. We talked about that. If he has AFib and he gets routine health care, what medicines is he going to be on? Blood thinner, right? So now I got a guy with belly pain, pooping blood, makes me think high risk for having a bad outcome because he's on a blood thinner because he has AFib, right? We also think, with his COPD, maybe he has a baseline increased work of breathing because he has COPD. Folks with COPD and asthma, if they have abdominal injuries, abdominal issues, abdominal pain, distension, it pushes up on the diaphragm, makes it harder for them to breathe. So if they already have underlying respiratory problems, it makes it worse, right? Maybe with the COPD, he's on steroid use. That makes people have an increased risk of infection, all right? With the AFib, we talked about bowel ischemia. That could be causing his belly pain. If your bowel dies from that, you can start crapping blood as well, high-risk patients. Maybe he has cancer because smoking leads to a lot of cancers, all right? Probably has underlying heart disease, whether he knows it or not. And does he drink a lot? Who here smokes only when you drink? Nobody raises your hand. Very good. Somebody smiled, though. I saw you. Very good. Yeah, me too, right? Sweet. And then vascular disease. People who smoke are high risk for having aneurysms, abdominal aneurysm. So just by knowing that he has COPD, I can infer all this stuff. And in my mind, I'm already making him high acuity patient. I'm gonna start moving a little bit faster, get my vitals, do my assessment, maybe pre-oxygenate. And I know he's gonna go to the hospital because he's an old dude, probably anticoagulated, crapping blood. Does that make sense? And I can get all that information in less than 20 seconds on a dude. Okay. You like that one? That's a good one. Yeah, no, that's one of my favorite ones too. Yes, sir. Yes, right. Yeah, so when somebody says they're pooping blood, the question you want to ask, is it bright red or not? Bright red blood means it's active bleeding, right? Now you can have purple poop, you can have melanonic, you can have dark black, and yeah, they're probably bleeding some, but bright red blood is sort of like you think active arterial going on right now or active venous going on right now. Plus I can talk long when you get to look at the slide. And just very good. Another minute, we'll change. So presentation of GI bleeds. If someone has bright red blood from their butt, it's usually an acute lower GI bleed. Older folks, you think diverticulum's causing this. It could be ischemic bowel pouring blood out as well. It could be from trauma. Hematemesis, cough ground, vomiting makes you think upper GI bleed. Melena, purple black stool makes you think upper GI bleed. Is that time to go through the GI tract and get digested? Okay. Any GI bleed is concerning. They're high risk for decompensating because there's no way to do direct pressure on those vessels, right?
So bright red is active, but like,
Right. So you,
are they bleeding out? Like they're physically bleeding out?
yes, that would be my concern. Yes.
Bright red blood, well, we always said, well, it's probably just a
Hemorrhoid. Yeah, right. So from an ER standpoint, I always think hemorrhoid last. So if I got somebody that's high risk, I'm probably not gonna think hemorrhoid. I'm gonna think something deeper and work them up for that. So that way, if I'm right, I catch the problem and I fix it. If I think hemorrhoid first and they're anticoagulated, have bad problems, they can crash on you. So for me, saying active, maybe I should say acute. If they have bright red blood out their butt or they're vomiting bright red blood, I think they're a critical patient. That's high risk that we're having an active bleed, arterial or venous right now. Black blood, black stool, melanotic stool makes me think, yes, at some point you were bleeding in your GI tract and it's either now or earlier, but at some point you were, right? And I can look at the patient and say, okay, your heart rate's 140, your blood pressure 70, this is bad, okay? But bright red blood out the mouth, out the butt, even with normal vitals, should make you very uncomfortable and think about rapid transport. Does that make sense? Okay. I think my caffeine's wearing out. That's not good. So diverticulums, the older we get, your colon has these little out pockets that pop out. It's just part of life. The problem is that you also have blood vessels that run through your colon. And if this little slow progressive out pocket runs across a blood vessel, it will break that blood vessel and you bleed. If you're not anticoagulated, you might get some black stool, may have a little bit of bright red blood for a minute or two. Not a big deal. If you're anticoagulated, that can't clot because we've stopped your clotting process. So now they just continue to bleed. All right. It's not like that scalp laceration that we see in the field from somebody that falls. Scalp lacerations aren't really scary, and unless they lay on the floor for 8 hours and not being seen by somebody, and they bleed and bleed and bleed. Same kind of process here. These are diverticular bleeds. So red flags for GI bleeds will be age, mature people. All right, and I'll leave that there. Bright red blood per rectum or bright red blood out the mouth hole is always bad. Blood pressure, obviously people with low blood pressures, hypotension, and GI bleeds are high risk for having bad outcomes. But you also got to remember the deep south where we practice, normal blood pressures are not the 120/80. We got folks that live at 190/100 every day. So now you got somebody that's got blood coming out the butt and blood pressure of 140 systolic, they could be hypotensive for them. So don't get bit by that. Heart rate should be high. What if this guy's had a heart rate of 60 and a blood pressure of 90/70? Why would he have a low heart rate and a low blood pressure? He's on beta blockers. Yeah, he's got COPD, he's got all kind of health problems. That's part of that little blue pill he was talking about, right? So don't let the heart rate bite you either. You look at everything, put it all together, and not just use one vital sign or one history to kind of guide your care. History of AFib we talked about means he's probably anticoagulated. All right. All right. So same guy, his wife comes in. All right. So now we know he's rich. That was funny. Maybe not. All right. What? That was the other different blue pill. Yes, sir. Okay. We're not going down that track today. All right. Yeah. His wife says, yeah, he's on Pradaxa. He's had a blood clot before. So Pradaxa is a thrombin inhibitor. We know it's a blood thinner, right? All right. He's got abdominal pain, bloody diarrhea, heart rate's in the 60s, blood pressure is in the 80s. So he's probably beta blocker or a calcium channel blocker. He's hypotension, right? He's breathing fast. He's saying 91%. The question is that due to his COPD and his underlying history of that, or is he just metabolic acidosis and breathing fast? Glucose is 226. That's a little bit high, but from our standpoint, we don't care. We care if it says low, and we care if it says high. Everything in between is just fluff. So our brain should be thinking, okay, lower GI bleed, bright red blood, anticoagulated diarrhea. Needs to go to the hospital. This guy's really sick. We can start IV access, give him some fluids. We can start moving toward the hospital. Perdax is a direct thrombin inhibitor. When he gets to me in the hospital, you tell me he's on that. I'm very concerned about the fact that he has the hypotension, right? And he's cramping bright red blood. I can give him a medicine called, where'd it go? What's the fancy name for it, Dr. Brown? Help me out. Praxibine, there it is. Thank you for helping me out, man. Appreciate you. Good. Yes, that's okay. I only went under for a few minutes. I bobbed just a little bit. That's good. Yeah. I was thinking Digibine. I said, but that's not it. Digoxin is that. Yeah, right. So this stuff used to be used a lot. We actually use a lot more of the PCC for this. This is fairly expensive as well. But Perdaxibine is what you can do. And that completely reverses that thrombin inhibitor. So if he has a small GI bleed, a small diverticulum which is pouring blood out, potentially we can give him a couple of doses of this, and then we can make it where he no longer is going to have that GI bleed. But remember, he does have a PE, all right? So he's going to have to go back on this at some point. But right now, his risk of dying from a GI bleed is pretty high. So in the hospital, supportive care is going to be pre-oxygenation. He's going to get IV fluid. He doesn't get like 8 liters. He probably gets 20 to 30 cc's per kilogram. We give him blood products because we know he pooped out blood. I give him platelets because without platelets, you can't start all those clotting factors we talked about. He's probably on an aspirin too, right? But he gets platelets from me. He gets fresh frozen plasma. That's all those extra proteins that are in there, right? I can give him some little bit of extra calcium is needed as well. We talked about the Perdaxibine, and that stuff's pretty expensive, but the price is coming. Same guy now with Xarelto, right? And that's a factor 10A inhibitor. So same therapy at the hospital, except now I can also throw in that PCC that we talked about. 4-factor PCC will fix this because it carries factors 2, 7, 9, and 10. My point to this is there are medicines that you can give at the hospital to reverse these issues. So these medicines are getting more inexpensive, so more hospitals have them. In the past, it was kind of limited to academic centers because we had the access, bigger patient flow, more access to get these medicines. But now even some of the regional hospitals, smaller hospitals can get this PCC and reverse this stuff. So main thing with GI bleeds, you need to recognize they're ill. You want to expedite transport. Fluid bolus early on to keep the blood pressure up, but limit to probably 20 to 30 cc's per kilogram. When you get to the hospital, stress your concerns to the doc. So you're being triaged in, walk over, find the physician at where you're going to take this patient, and let them know, hey, I got a 70-year-old guy with a GI bleed. He's got bright red blood coming out of his butt. Okay, make it obvious that everybody knows what's going on, and he's anticoagulated. He's on Perdaxa. He's on Xarelto, whatever he's on. And that should put fear in the heart of that ER physician, and they should get up and walk over because we have all seen that GI bleed patient go from okay-ish to cardiac arrest. GI bleeds pretty quick, and it will instill fear in you, right? TXA, I know that question was coming up. So can you use TXA in GI bleeds? There was a study, the HALT-IT trial, and they looked at a large volume of patients that had GI bleeds and got TXA, and their findings were that people did worse with TXA in a GI bleed. That being said, my opinion is that this study was wrong. This study looked at acute GI bleeds, the bright red blood coming out the butt in the mouth, and also the melanotic stool, the slow GI bleeds. Slow GI bleeds, this probably TXA doesn't help because remember TXA, what it does is it tells the body, don't break down your clot to look to see if we still need to use those proteins, hold that clot still, all right? So if I got somebody with bright red blood, that makes me think they have an acute bleed that's probably less than 3 hours old. They get TXA, just like trauma. If I have somebody who has a slow GI bleed, melanotic stools, they've been dropping their blood counts a little bit each day for 4 or 5 days, and now they're anemic and look like dirt, TXA is probably not going to help them because they've already exhausted the clotting factors that TXA tries to preserve. All right. So my opinion, I use TXA on GI bleeds. Some folks will not, but I do. Do you use them? Yeah. I think it's acute. Yeah, right. So if it's a chronic GI bleed, they can get blood products, they can get platelets, everything else. They don't get TXA. My point for you guys in the field, you got a guy crapping bright red blood, unstable. He has signs of hemorrhage, right? It's less than 3 hours probably. TXA is a reasonable drug. I don't think there's a risk at all to it. Besides, it's the most common drug we have to use, right? Is what we got. So heparin. So we talked about people who have stents or STEMIs, and we put stents in those guys. They get dual antiplatelets, so they get aspirin and either Brilinta or Plavix. We also give them heparin. Heparin is an injectable drug. It's approved by the state to be used for pre-hospital. It has to be approved by the hospital you're taking your STEMI patients to. But what heparin really does is heparin binds antithrombin so that you cannot clot, right? So it makes it where the thrombin does not work. All right. It also does some other things over in this area. Don't make me make it up, but heparin makes it where you can thin the blood out by jacking up thrombin. All right. Inappropriate humor for the older generation. Got to keep you guys happy. Chief Ward. There we go. The old people in the classroom laugh. Questions, comments, statements so far? Good, 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 good. Yes. So this is a guy that fell from standing, maybe got knocked out. He's awake and alert now. Vital signs are stable, but his wife says, yeah, he's on Coumadin. So what's your first thought be? High risk for bleeding out. Scalpel acts are normally pretty bloody. He's on Coumadin. This could be bad. And worse, he could have an underlying head injury because he was also kind of knocked out for a few minutes. So I'm gonna do direct pressure. I'm gonna palpate the skull. If there's some crepitus, if the bone moves, that's a bad thing, right? But I still need to direct pressure. Things I can do in the hospital to stop the bleeding is I can throw a few stitches in there. I can put some lidocaine with epi through this. You guys can use some TXA topically as category B, but if you have the TXA that's in the vial, not the 100 ml bag, you can draw that up and put it over the wound and direct pressure. You could do a little combat gauze. You could do something to make this stop bleeding because he's going to be bleeding like a freaking bear, right? So we can stitch it. We talked about TXA. If he has any signs of shock, he has signs of hemorrhaging, all right, hemorrhagic shock, TXA is category A. If you want to use it topically, it's category B, the Cat A. Coumadin, the most common, oldest anticoagulant we got, jacks up 9, 10, 2, and 7. And again, that's why we made the PCC, is to fix the Coumadin issues. Again, $4,000 to $6,000 for this stuff. The other thing is that Coumadin works via the vitamin K. So we have to give them vitamin K as well. We give that in the hospital. We used to give it IM or sub-Q. There was a risk of anaphylaxis. For the critical care guys and nurses out there, we don't do that anymore. If someone needs to be reversed from their Coumadin, that means they're probably sick, high risk of decompensating or dying. So they get vitamin K IV, 5 to 10 mgs. If we just give them PCC, a little while later, the Coumadin is going to kick back in and work on the stuff that we gave them. So they'll still bleed. So we give them vitamin K, the PCC, and we reverse it that way. We talked about TXA already. TXA is a relatively safe drug with some good benefits for folks who are bleeding. Semi-inappropriate humor. There we go. So 37-year-old, history of DVT on a blood thinner and a nosebleed. How do you manage that? What do you do? You say, why'd you call 911? I know what you say, but you're not supposed to say that. All right. Direct pressure. Yeah, direct pressure. Yeah, yeah. So you think about the nose, it's got the skin, it's got cartilage, and it's got mucosa. The mucosa has vessels in it, arterial vessels. There's the Kesselbleck area. I usually think of that guy for some reason. I don't know why I call it Hasselhoff, but it's not the same dude. But the anterior portion and posterior portion, right? So lots of things can cause nosebleeds. You got trauma, you got allergies, NG tubes in the hospital. During the area of COVID, we had those big cannulas we stuck in people's noses. It would scratch and tear people a lot. And then obviously there's medications that can cause nosebleeds too, right? So the way I manage this is I kind of do pressure, exposed, pressure, enhanced clotting, and then pressure. So direct pressure, nobody holds their nose hard enough. All right. They make some commercial devices. Nobody does that either. So what you do is somebody on scene is again vital signs, somebody else walks over and just gives them a good pinch. And then you talk to them. Hey man, Alabama or Auburn, what's your mama do for a living? Talk about something, right? Make them laugh. And you hold that a good 6, 8, 10 minutes. All right. Then you can let go. If it stops bleeding, the day is done. You do your PCR, you high five them. Do you want to go to the hospital? No, great. Thank you. Have a nice day. And you move on. If that doesn't work, the next thing that I'm going to do in the hospital when you get to me is I'm going to look in the nose. I'm going to look to see if there's a laceration, an ulcer, something that I can inject with some lidocaine with epi. And this is silver nitrate. This touches the mucosa. It kind of burns it so I can cauterize scratches or tears in there. Afrin is a great drug. Squirt that in the nose, 4, 5 squirts of that, and then direct pressure again. So I'll do this, and then I go back and I pinch their nose for another 8 minutes, hard as I can. They don't really like me, but that's okay. All right. If that doesn't work, the next thing I'm gonna do is I'm gonna go back, I'm gonna do more pressure, but I'm gonna do it internally. So I can use some nasal packs. All right. Nobody ever thanks you for it. Nobody appreciates it. These things are really uncomfortable. The literature says we gently place these in the nose. In reality, you shove it up in their nose. And most of the time I give them a little medicine to make them not hate me as I do it. But again, bleeding from any source that's uncontrolled can lead to hemorrhagic shock, can kill people, and that's poor form. There's some commercial devices out there that work pretty good. This one's nice. It's got a balloon you can inject with either air or saline. This is kind of a kaolin based, I think, anticoagulant. So when you put that in the nose, it'll stick to the mucosa and stop the bleeding. Sometimes I'll dip that in TXA or dip it in lidocaine with epi or cover it with Afrin. This is a similar thing, but it's like a tampon on a stick. You stick that at the edge of the nose, you push it in, and then as it expands, it stops the bleeding. Yes, sir. People do not appreciate it. It's very painful. Yeah. So I try to avoid this. The people that I usually end up doing this to are folks that are anticoagulated, that have some kind of injury to the nose. These things can stay in 24, 36 hours. I'll send people home with these, but they got to go back to either the ENT specialist or the regular doctor to do that. But nosebleeds, usually you can stop with direct pressure or Afrin or then TXA in the nose and direct pressure. If not, you have to go to this. They make a thrombin spray. So if somebody's on some anticoagulant, you can actually put topical thrombin in the nose. It works pretty good. I mentioned the TXA. Sometimes you cannot do this. It's not FDA approved, but you can put it on a mister and kind of squirt it in the nose that way, and it works pretty good to stop the bleeding. And then there's thrombin topical, which again is on that clotting cascade we talked about. There's been a couple of times that you can, I've used some cocaine as well. They still make medical or medicinal cocaine. So if these things don't work, you can always do a little cocaine. There was a demented lady from a nursing home that we stopped her bleeding. Then she started picking her nose, scratching her nose, started bleeding again. So we packed her nose, and then she reached up and pulled the packing out. So our options were restrain her and keep her nose packed, which is bad for people, or try something different. So a little bit of cocaine in the nose, hold it tight for a few minutes, put on the Eagles, and she was like really happy, and she quit having a nosebleed, and I got great Press Ganey scores on that one too. There you go. All right, so remember there are 2 different pathways. For the EMS folks, you don't have to memorize this stuff. That's not what I'm saying, but I want you to recognize it is a complicated process. There are a lot of things to go into play for this. There's platelets, there are other proteins, there's calcium. The goal of all this is to make a clot. We have lots of patients on medications that screw up the factor 10, the factor 7, the factor 2, and you need to kind of understand this to know that if they're bleeding out and on these medications, there's a high risk. They can't control their own bleeding. We've got to control the form. If we can't control it with direct pressure, you get to the hospital and we give medicines to reverse this stuff. Okay. All right, so summary, main thing we do in the hospital is folks anticoagulated with hemorrhagic shock because we can reverse it. Head injuries, we can use that Andexa, the activated 10A. We can use that activated 10A. at the institution I work at UAB, that has to get approval from neurosurgery because it's so expensive, but we have used that before. We can use blood transfusions, platelet transfusions. So there's some controversy out there. People on aspirin that have head bleeds, do you give them platelets? There's one school of thought that says, well, if I give them platelets and they just took their aspirin, that aspirin is going to mess up the new platelets and it doesn't do any good. There's no school of thought that says, yeah, they have blood in their head, and if we can stop the bleeding even for 30 minutes, maybe we improve outcomes. I'm of the school that I give platelets to people with head injuries, head bleeds on aspirin or antiplatelet medications. We talked about the Andexa. TXA is mentioned twice in this plan, so it's very useful. All right, platelets we mentioned, and then PCC. All right. This is more for the critical care folks, the hospital folks. If you're reversing somebody that's on Coumadin, you got to give vitamin on Xarelto or Eliquis with the PCC, and they just took their medicine. You may have to repeat that dose in a couple of hours, and you determine that based upon the clinical exam. All right, thank you for staying awake. Questions, comments, statements within reason.
Yeah, we actually had a couple of questions come in. So the first one is for services that are thinking about obtaining point of care lab testing like iStat with regards to bright red blood from the rectum. If they obtain a sample and the H&H is 12/42, but demonstrates poor skin and vital signs, and you have blood products available, do you just go down that pathway? And why are we seeing those? Why do those lab values look good at any time? Or can you explain why?
Yeah. So when you look at it, a CBC, the only parts of that CBC that really matter from the ER or even EMS, right? So the hemoglobin, hematocrit is the amount of blood the body has circulating. The problem is even in trauma or GI bleed that's acute, when you draw this blood, the first hemoglobin, hematocrit may be normal. Because if you think about it, if I took a 2 liter of Coke, right, and I poured half of it out, the Coke that's left still looks dark like Coke, right? Okay. But now, if over the course of 10 minutes, I put 30 cc's of Sprite in that Coke, after about an hour, that Coke's going to look thinned out, right? So the body's the same way. If I got an acute GI bleed and I crap out a liter of just blood, the remainder of my blood's still going to look normal because I just spent half of it, right? But the body's response is going to take third spacing of fluid, bring that back into the vascular bed. You start IV, you give them fluids. It's going to dilute out the blood they have. So that second hemoglobin may be low. The point of that is the first blood test in a trauma patient or a GI bleed doesn't matter. If their blood count is low, that tells me they were anemic before they crapped a bunch of blood out. So they're even probably sicker. But to answer his question, if I had somebody with a blood count that's normal and they're crapping blood, the vitals are unstable, they get blood products right then. So you give the blood based upon clinical exam and the risk or mechanism of injury.
Gotcha. So the other one, I think you already addressed this. I think this is referring to the nosebleed. Is would atomized TXA work?
So there are no studies to do that, but I can tell you that I know that it is being done. But I would say that needs to be category B. Okay. And I also think that the other thing is before you start doing medicines in the nose hole, you need to make sure you go and do good direct pressure. So if somebody's holding their own nose, they're not going to hold it tight enough. So like I'm not going to put a tourniquet on my arm tight enough to stop the bleeding. So if you're holding direct pressure for 8-10 minutes and it's still bleeding, you put Afrin, direct pressure 8 minutes, still bleeding, then yeah, something topical TXA is fine. I've seen it more used where I'll put the TXA in that nasal tampon and put it in there, or maybe I'll wrap in the hospital surgeon cell and pack that up in the nose. There are different ways to do it. So it can be done, but it's not approved for that.
Okay, people are also asking about the use of quick clot gauze for nosebleeds.
I probably would not do that, but again, it depends. I got somebody that's about to die because they're pouring blood out the nose. Sure, no harm, but you're probably better off with direct pressure. Other questions, comments, statements?
That's all the questions we had online.
Okay.
We're going to talk about at-risk populations, so not quite as fun of a topic as Dr. Ferguson's lecture, but very important nonetheless. So we're going to talk about intimate partner violence, domestic violence, the other word for it, sexual assault, and then child abuse or child maltreatment. I will tell you some of the images are a little disturbing, so I apologize ahead of time, but there are some things that you might see. All right, so we'll start with intimate partner violence. So what is it? So it's the intentional use of tactics to gain power over the thoughts, the beliefs, and the conduct of an intimate partner. And that intimate partner can be a current or a former girlfriend, boyfriend, or spouse. And what it does is creates fear, isolation, and entrapment of the person that's being abused. So most non-fatal victimizations actually occur at home. So really you as an EMS provider at a unique position because you can see the environment in which that violence took place. You can observe the behaviors between the abused and the abuser. And if you're aware of what constitute these behaviors and interactions, it can allow for early intervention. So how common is this? So intimate partner violence occurs in all countries, really regardless of social, economic, religious, or cultural statuses. And it accounts for 20 to 25% of ED visits by women, which is a lot. It's the leading cause of injury to women ages 15 to 44, and it accounts for 1 in 5 homicides that involves killing of an intimate partner. If you can see on the picture on the right, so at least 1 in 4 women and 1 in 7 men are victims of severe violence from a partner at some point in their life, which is really common. So what are the high-risk groups? So patients who are recently separated, divorced, usually that's really kind of the scariest or most critical time for these patients. People who are minorities, those that live with a disability, and then women who are pregnant. All right, so how does it start? So usually intimate partner violence often begins in a close mutual relationship. So over time, you get together, over time that relationship becomes more exclusive. And as it becomes more exclusive, the abuser can isolate the victim. And then they can start violence kind of gradually or suddenly, but usually there's a period of testing. So they might, start verbally assaulting their partner, and then once that's tolerated, they start physically assaulting their partner. And so they can start shoving, pushing, and then that can escalate to punching, kicking, or assaulting with a weapon. So there are different forms of abuse. So there's physical abuse, shoving, kicking, biting, verbal abuse, emotional or psychological abuse, sexual abuse, spiritual, not allowing person to pray or go to church, and then financial and material. So withholding funds from people, not allowing them to go get the food or clothes that they need. So there's this cycle of violence that's talked about. So the first phase is when that tension starts building. So the tension starts building between the partner, the victim, and the abused. And so the victim tries to start increasing attempts to please the abuser so that they don't get harmed. But then they may intentionally trigger that abuse at specific times. So say there's a couple, and this can be male-male relationships, female-female, or male-female. But say the couple is about to go out to dinner, and they'll say the male is abusing the female, and the female really doesn't want it to happen when they're out to dinner. So the female may intentionally trigger her partner to abuse her at that time so that it doesn't happen when they're out in public, so that it's not seen. So that's the first phase. And then the second phase is when that violence erupts. And it can increase in frequency and severity over time. And then there's usually a honeymoon phase where the abuser starts apologizing for the abuse, starts purchasing gifts for the victim, and then offers rationalization. So this is why I did this. This is the cycle. So the tension starts building, there's an eruption of violence, and then there's the honeymoon phase, and then it starts back over. So this cycle of violence can occur generationally. So children that witness abuse may learn that it's tolerated and that it's an appropriate way to gain control over someone, and they may repeat that behavior in future relationships. So why do we care? So 1 in 4 women in the ED for any reason is a victim of violence. And then 1 in 3 women that are treated for trauma. And then about 18% of those female victims use an ambulance service. So really, EMS providers are often the first responders to these situations that involve violence. And if you identify that there is violence, there's really an opportunity to intervene early to improve the health of the person who's getting abused. So in the hospital setting, in the EDs and primary care settings, we use a universal screener. Have you ever been assaulted verbally, physically, etc., by an intimate partner? So everyone is asked. So what are things that you can look for if you're on scene and there's an argument between a couple? What are things that you might want to look for? So you'll look for those physical effects. So any kind of fractures, burns, bruises, patients that may complain of like chronic abdominal pain, chronic pelvic pain, emotional or psychological effects. So women who or men who are experiencing anxiety, insomnia, they may have PTSD, they may be self-harming themselves, they may have thoughts of suicide, or like sexual effects. So women who have had multiple pregnancies that are close together, that may be desired, unwanted pregnancy, miscarriage, people who get frequent STIs or sexually transmitted infections. So once you suspect that there may be intimate partner violence going on, make sure that the scene is secure, because you really don't want to get in between a couple that's fighting. You want to make sure that if you are on scene with this, that you know where the door is and you know how to get out of the building. And you want to make sure that that abuser does not get in between you and the door. It's the same for like a psych patient. So what are you looking for? So you're looking for any kind of abrasions, bites, bruises, burns, fractures, dislocations. You can see this picture of the marks on the neck or signs of strangulation. You can also look in the eyes, and they might have petechial hemorrhage from being strangled. If they have any kind of pattern injuries, so if they have injuries on their forearms from like trying to protect themselves like this, they might have dental trauma, or if you see an injury and it really just doesn't make sense how they got it. Those are all things to think about. So you obviously treat the patient, their physical injuries first. If for some reason they have a hemorrhage, you're going to treat that first. But if they're stable and everything looks okay, try to do a quick behavioral assessment, really to just observe the environment and the interactions between the victim and the abused. So the abuser might be hovering, they might insist that they're present during an exam, they might answer for the patient, or they might be overly friendly with you to account so that you won't see what's going on. Or they may minimize the injury that happened, lack sympathy, or blame the patient. And then the victim might be evasive, guarded, might avoid eye contact, and then they may look toward the abuser for guidance. So how do you ask about abuse? So you want to ask about it in a private setting that's away from someone who might be abusing them, because you really just want to let them know that, hey, abuse should not be tolerated. And if this is something that's happened to you, we have resources available for you. If there are children present, make sure that they're not present when you're asking about abuse, because little kids go back and repeat everything, right? And we want to make sure that they don't know, like if the male's getting abused, they don't go and tell whoever's abusing them what happened. Separating the victim and the abuse can really be challenging, and this is challenging in the emergency department too. One way you can get around this is to have one provider take the partner into another room to try and ask health history questions. Say, I just need to know what's going on. Can you tell me about their history? Or if they insist on being present, take the victim to the rescue and say, I'm sorry, but this is only for patients. And so that partner can't come. So we really want to encourage disclosure. So these are a couple things that you can say to the patient, to not say, hey, I think you're abused, but to kind of get around it. One of the most common ones is the bottom one, is more something that's used in the ER or primary care setting, just to screen. So violence against women or men has become a healthcare issue. So I ask all of my patients whether they've experienced abuse or violence as a child, adolescent, or adult. So if the patient says yes, we want to make sure that they're safe, right? We want to make sure that the partner, if they're there with you, that you can get them to a safe place if they want it. You can ask them if they want to talk about it. If they don't want to talk about it now, there are resources available. There's hotlines that they can call, or websites that they can search. You know, we want to ask, have you ever talked to anyone else about this? We want to make sure that they have a support system available. So if they, you know, move to some city that they have no friends in, no family in, they probably don't have a great support system, because their friends are probably their partner's friends as well. And then you ask them, you know, what do you need now? So that they know that you're focused on them, what they need. And so if they go to the emergency department, you can tell them what they told you. If the patient says no, don't force the disclosure. Most patients really just appreciate that you're asking them. But things that you can say are, you know, if they say no or think that you're crazy for asking them if they got abused, say, I ask all my patients about violence. I just want to make sure you're aware of any resources that are available in case you need them. All right, so what are some high risk things that we should be aware of? So things that are related to an increased risk of further violence, or if there's an increasing frequency and severity of the violence. So if the patient, you know, usually just gets kicked and now their partner has a weapon and they're threatening to use that weapon on them. If they have access to a gun, if they're using drugs or alcohol, or if it's a female partner and they're pregnant. Women that are injured by their partner often decline transport. Obviously, the bad thing about that is that they don't have the availability of the resources that we have in the hospital. But it's important for y'all to know what other resources there are available to provide the patient in case they refuse transport. And we'll talk about some of those. So when you're doing your documentation for this, if you're suspect intimate partner violence, or you know for sure, hey, their partner hit them and now they have a laceration on their head, you want to make sure that you're documenting this well in the event that that partner, the abused, presses charges and this ends up going to court. So know any patterns or of blood injury. So if they have injuries on their forearm, they have any lacerations, any penetrating wounds, we want to try to make sure not to disturb the crime scene or the patient if we can. Obviously, if they are bleeding out or they're unstable, we're going to do what we need to do to help them at that time. But try to keep their clothes intact. Everything's, you know, that I read for this lecture says to put everything in a paper bag. It's obviously not very ideal in an ambulance setting. You probably don't have paper bags, right? Yeah. The police may have a paper bag on them, but just put it somewhere that's clean and that you can try to seal it up the best you can. Yeah, and then they will probably, whenever they either get to the hospital or if you give it to the police, they'll probably change it over. Because really the point of this is just to make sure that what you get on scene is the same thing, that if it gets presented in court is the same thing. But we need to have realistic expectations. So our role is to provide medical treatment for these patients, but also support them and empower them to make the decision that's best for them. We can't fix these patients. We can help them the best that we can. You might not agree with the decisions that they make, but obviously they're living their life and they're the decision maker for themselves. I think one of the scariest things is that domestic violence doesn't always end when the victim leaves the relationship. That's one of the most dangerous times, is if that victim decides to leave. And then, so some of the reasons that victims return to abusive relationships, some of these are, I don't know the word I'm looking for, but you would know this. So if the patient's fears their personal safety of their children or pets, so say their partner is threatening to keep their children from them or harm their children if they leave, they're not going to leave. Maybe they have low self-esteem, they have economic issues, so they don't have any financial freedom from their partner. If they're isolated, so they move to some city where they don't have any friends, no family. Maybe they fear that they're going to get deported. They don't know their legal rights. In some cultures, the family may blame them if their relationship fails, if they leave. They might not know what their options are. And a common one is he's not always abusive or she's not always abusive. So these are some resources that are out there. So the first one, the National Network to End Domestic Violence, is a website that it's national, but there are specifics for Alabama. So it has lists of resources like shelters, advocacy programs, ways that they can press charges if they want to talk to police, if they want to talk to whoever. There are a ton of resources on that website. There's Crisis Services of North Alabama, which is obviously more for North Alabama. There's Crisis Line, so the domestic violence hotline. And then if you're aware of any area shelters where you are, and then making sure you know if there's a child involved, how to contact DHR or Child Protective Services. Okay, so reporting intimate partner violence is not mandatory in Alabama, unless obviously you suspect child abuse as well, then it's reportable. But the victims can file police reports, so you can always encourage them to do that. Any questions about that?
I have a comment about that.
Yeah.
Evidence.
Yeah.
I would recommend to medics, especially that work in the fire service, to contact their fire marshal. They can tell them how to preserve that evidence
Perfect.
because they're not going to have.
How would you recommend doing it?
Depends on what it is. If it's clothing, I mean, you'd want to take a picture of the clothing before you cut it off of them or whatever you had to do. As you found it, and then, paper bag would be great, but you have to have evidence tape and
Yeah.
all sorts of stuff that's not going to be on a rescue truck.
Right.
But he can at least help you navigate those waters. If the 1 in 100 chance that happens,
Yeah.
but
So say the patient's unstable, they have like a GSW to their chest or something, you're trying to get their shirt off. Like, would taking a picture on your phone be helpful or no?
that's fine. Yeah, in that case, it's life or death. You need to do what you gotta do.
Okay.
I think the courts would understand that.
Yeah.
Because as a medic, your primary
Right, it's a
is to help the patient, so, yeah, I wouldn't get in the weeds about all that. I'm just saying
Yeah.
that if they find it necessary,
if they're
that-
stable.
yeah, their fire marshal could probably give them pretty good, because they're trained in collecting that.
Thank you.
All right, so we're gonna move on to sexual assault. So sexual assault is any form of sexual activity with another person without their consent. So there's various forms. It could be forced kissing, intercourse, participation in looking at sexually explicit photos. There are a lot of different forms of sexual assault. Women and men can both be victims, but most of the sexual assaults are usually men against women or children. And what is consent? So consent's an active choice or voluntary agreement between two people of legal age. And if you consent one time, that doesn't mean you consent all the time. So things that are non-consent, so a child can't consent. So someone at the age of 12 in Alabama cannot consent. Anyone who's under the influence of medications, drugs, alcohol, if someone is threatening them, or they submit because they're being threatened or forced, that's non-consent. If somebody says yes for you, that's not consent. Or if the person who is doing the abusing is in a power of authority over someone and that person that they are abusing felt threatened into being in a sexual relationship, then that is non-consentable as well. It also includes doctors, nurses, or other health professionals that do unnecessary exams. All right, so how prevalent is this? So it's a global issue, affects millions worldwide, actually claims a victim every 45 seconds. 1 in 5 women and 1 in 71 men have been raped at some point in their life. And in 82% of the cases, the victim and the accused know each other. But fewer than 1 in 10 victims actually report the crime to police. And why are they not reporting? They might feel embarrassed about it. They might feel like they're not going to be believed or they're going to be blamed for it. They may not want to have to go to court, or they may have been under the influence of drugs or alcohol and may not remember everything. So there is drug facilitated sexual assault, which is when the person who is being assaulted is incapacitated or unconscious because of drugs or alcohol. And that can be because someone gave them drugs or alcohol to make them incapacitated, or because they took them themselves. These are less likely to be reported, again, because the victim can't describe the event because they were under the influence. All right, so what are we going to do to take care of this patient? So things that we need to look for, they may, especially if they're under the influence of some sort of drug, they may have lost consciousness, they may feel dizzy, disoriented. Look for any bite marks on the face, the breast, those complications of strangulation, the marks on the neck, the petechial hemorrhage of the eyes, They may have rope marks, kind of all the same things as the intimate partner violence. But unless there obviously a severe hemorrhage or some sort of life-threatening general injury, obviously we're not going to examine the area so that they can get in evidence later. But knowing that these people are at risk for sexually transmitted infections and pregnancy is important, because some of these treatments that we give these people are only available within a certain time frame. So if somebody's exposed to HIV, we want to start treatment within 72 hours. If it's outside of that 72-hour window, they don't usually start treatment. They end up just getting tested for it. And then obviously things like pregnancy preventatives are also time sensitive. All right, so how else can we care for these patients? Just assume that the assault occurred. It's not our job to say whether or not it occurred. That's the patient, between the patient and the assaulter and the police or a court. It's our job to be non-judgmental, reassure the patient that they're safe, and then make sure that they don't have any life-threatening injuries that we need to treat. So legally, there's two crime scene locations. There's the location where the assault occurred, and then the victim, him or herself. So things that have to be proven for a sexual assault to have occurred, they have to have been in the same place at the same time. They had to have been some sort of sexual act, and then there was no consent. So make sure that your documentation is based on the assumption that whatever you document could be presented in a court of law. So I want to make sure that's accurate, it's comprehensive, objective, legible, and then timely. So you don't want to be finishing the PCR report, a week later when you can't remember it. We already talked about evidence, and then chain of custody has to do with the evidence collection. So want to make sure that the evidence that you collected at the scene is the same thing that gets presented to court. So what are the treatment options for sexual assault? So most states have a sexual assault response team or a sexual assault care center where there are SANE nurses. So it's a sexual assault nurse examiner. There's one that will come to UAB. There's one that usually some of the ER nurses at Children's are SANE nurses. So what we do, so usually if you bring in a sexual assault patient to the ER, if they are medically stable and have really no complaints, we will send them to the SANE center if they're open. If the patient is unstable in any way and we have to admit them, the SANE nurse will come to us at UAB in the ER. Versus at Children's, usually one of the nurses that's there is a SANE nurse, and they'll do all the evidence collection. They will do any prophylactic treatments for sexually transmitted infections, pregnancy, and HIV, start HIV treatments. So if the patient does not want to be transported after this, make sure that they, first off, are safe, and second off, that they know the resources that are available for them. And so for the Birmingham area, the crisis center, I think is in downtown, but this website has the address and the phone number that you can give to the patient, and they can go to the SANE center themselves to get treatment whenever they want to. They don't have to be seen in the ED first. Yeah.
Yeah, so I knew this was gonna happen as soon as you start talking about it. Does EMS transport to the SANE center? Does the SANE center respond to all EDs or just to UAB?
So the SANE will respond to any ED if you call them. As far as transporting, there was a trial done in the past, so that Birmingham, and I think there were two other agencies could take to the SANE center. We have not done that in a long time. I think COVID put a kind of hinder on that. I think that's something we should look into. And I think with med control oversight, that's a reasonable thing to do. But right now, I would say we're probably not doing that. There's been leadership change at the SANE center too, so we probably got to talk to them.
Can I bring something up? For guys that work in Jefferson County, we have had a request in the past from Jefferson County Sheriff's Office. If they do not have a medical or traumatic emergency, that they would prefer we get a female deputy to come and take them to SANE in a police car, so that all the chain of custody stuff is done and all that. They would really prefer we didn't transport them.
Yeah.
And there can be some confusion out day to day with that, because we get new people, they get new people that don't know. You may have to be the one to explain to them, hey, no, they need to go with a female deputy to this place. because the chain of custody and evidence is all gonna be compromised when they get in the truck with me and I'm not a law enforcement officer.
Yeah, I got no problem with that. If the patient is stable and is agreeable with that, that's fine. I don't see a problem with that.
It's not open 24/7.
No, but in the past, they've had someone on call that we could
Yeah, so
contact.
they'll come to the ER.
Right, and they've met EMS at the same center before. But we just have not done that recently due to COVID, is my understanding.
And I would suggest, this is a question really. What does everybody think about, if we're transporting a victim of sexual assault? There's not always gonna be a female available to ride the back, but I think it's a good idea anytime we're in the circumstance to have two providers in the back of the truck, just for give witness, just to protect us and the victim.
If you have two people available.
Right.
And sometimes, so personal opinion here, sometimes if they're stable, you're better off not asking a lot of questions or doing a big exam either. It just recognize there's been an injury and make a determination, we go to the ER, or if we can go to the same center, do that. But there's no reason to do a complete exposed exam, everything, and there's their life threats found.
So like even in the ER setting, we'll make sure they keep everything on, well, like all their bottoms on, so that we don't need to get a urine sample from them, so that they can do all that at the same center.
Very good. Thank you.
All right, so just in conclusion, for intimate partner violence and sexual assault, so really these calls can be extremely difficult. Make sure that the scene's secure before you go. If the patient declines transport, make sure you know about resources that are available to provide them. If they do accept transport, make sure that all the information that you have is reported to the healthcare provider that's taking responsibility for the patient, and then make sure that you finish your PCR ASAP and that it's accurate and comprehensive, so that if they do choose to press charges or go to court, that they have that documentation. All right, so now we're going to talk about child maltreatment. So there's child maltreatment is any act that results in the harm or threat of a potential harm to a child. So there's different forms. So there's physical, psychological, sexual abuse, but then also neglect. And neglect is failure to provide adequate food, shelter, clothing, medical care, dental care, or education. Or it can be exposing the child to a dangerous environment or not providing adequate supervision. So just so y'all know kind of some of the numbers, in 2011, there were 3.4 million referrals to Child Protective Services. That involved 6.2 million children. They found that about 700,000 were victims of abuse or neglect, and the majority of them experienced neglect, so that inadequate food, shelter, clothes, medical, dental care, etc. About 20% were physically abused, and so on. But about 1,500 of those children died because they were abused or neglected. The patients who are most vulnerable are those that are infants, people who are pre-verbal, and then those with chronic diseases and disabilities. So what's our role? So you are the first line of defense, because you can see the scene, you can see the interactions between the parent or guardian and the child, see the home environment. And it's important to know that the mortality of these children is higher if they've experienced repeated non-accidental traumas. So if you suspect child abuse, it's important for us to implement appropriate interventions at that time, because if they get abused once, then they're more likely to get abused again. So what are things we want to know? We want to know, how did the injury occur, when and where did it occur, who witnessed it, and what's the child's medical history. The chances of the child being able to tell you all this is pretty slim, or the parent, if it's a child abuse case, the parent might have coached them into telling them what to tell you. So we want to make sure that the explanation is credible. So if there is a 2-month-old that they say fell off the bed, that probably didn't happen, right? Like, that baby can't probably roll. They can't crawl, they're 2 months old. Does the injury pattern fit the description of the accident or the incident? So if they have some sort of fracture, does it make sense what they told you happened? Was there any delay in seeking care? And then was the child appropriately supervised? So what are we going to do? Obviously, we're going to treat the ABCs, your primary survey, treat any life threats first, and then try to do a careful examination of the child, especially if they look okay, but the story seems a little iffy. Because the most common manifestations of child abuse are skin injuries. So we want to look for any kind of bruising, which is going to be rare. If an infant that's not crawling or walking has a bunch of bruises, that's a little iffy because they usually don't get bruises. Look for bruising on the upper arms, the medial or posterior thighs. If you see any bruises, like in this lower picture behind the ear, that's not somewhere where anybody would ever get a bruise, correct? Unless you fall back and hit your head, maybe. And then any kind of bruises that demonstrate a pattern. So if it looks like cigarette burns on the patient, try to make a note of that. So here are kind of the normal and then suspicious bruising areas. So the picture on the left is where people normally get bruises. So the elbows, the knees, and the shin. That's usually from falling and hitting things. If the patient has bruising on the back of their thighs, the back of their calves, their buttocks, behind the ear, those are more suspicious because those are harder areas to get bruises. And then burns and fractures. So abusive burns account for about 10% of all pediatric burns. Most commonly are scald burns or immersion burns. So if you see in this picture, when we say immersion burn, it's, like the child is getting dipped in hot water, hot scalding water, or hot scalding water is getting poured on them. So like in this, so say the kid they're probably going to be with their hips flexed in the water. So that's why in their inguinal crease, there's no burns, or their buttocks because it's against the bottom of the tub, and then the back of their legs because they're together. And this obviously looked like a clothes iron burn, look for cigarette burns. And then 11 to 55%, which is a very wide range of pediatric fractures are a result of abuse. And the majority of fractures that occur in kids less than 1 are a result of abuse. So if you ever have a kid, a small child that's less than 1 with a long bone fracture, it's really hard to break a long bone. So that's probably from abuse. If they have rib fractures or like a bucket handle fracture, which you're not going to know in the pre-hospital setting, but those are all suspicious. There are some medical conditions that can be confused with child abuse. So asking a good history is important. So if the kid has hemophilia or like a blood clotting disorder, if you ever heard of hemophilia, yeah, so there's two different types, but it usually causes like big, like hemorrhagic joint effusions. So if they fall and hit their knee, they can have a big swollen up knee that's full of blood. It's because they're not clotting appropriately. Or in the top picture, the kid might have Mongolian blue spots that look like bruises on kind of above the buttocks area, but that's just something that these children are born with. So if you ask mom, hey, or dad, hey, how long has this been there? And they say, oh, they were born with that, then it's probably okay. So what's our duty? So all states in the U.S. require reporting suspicions of child abuse. So making sure you have an accurate, detailed written documentation is important. And making sure that you are relaying all your suspicions to whoever is accepting the patient. So ways we can report in Alabama, we can, obviously, if you're taking the child to the hospital, relay to the nurse, to the physician, so that they can get social work who gets DHR involved. If you go to Children's, they're really good about this. Some of the ER doctors there are child abuse specialists. Or you can make a report to DHR. You have to make an oral and a written report. And then there's instructions on how you can do that on there. All right, so in conclusion, as an EMS provider, you're really in a good position to provide information and recognize child abuse so that we can intervene and making sure that you're documenting a good history. All right, any questions, Chief? Any questions from the room?
So there's always questions about how to accomplish the reporting, like you just mentioned. So it's my understanding that if we report suspicions to receiving hospital staff, we've satisfied that requirement. Is that right?
I believe so, and the hospital should do the appropriate documentation. from that. Usually we get social work involved, who then gets CHR involved.
It's also been my experience that that's the most effective. I know when we tried to call Child Protective Services or Adult Protective Services as an agency, as an EMS agency, we tend to not get very far as fast as the people who deal with them all the time in the hospital do.
Yeah. I think the important thing is that if you suspect child abuse, just do your best to be able to get that kid to the hospital. Because the hospital obviously has a good relationship with DHR, CPS. They have all the resources available, and we want to make sure that kid's safe.
The other option is, if you're not convinced the hospital takes your concerns seriously, or you can't get them to go to the hospital, then you pass up the food chain. If you talk to your medical director, they have insight, they have the ability to use the hospital resources to get that reported. You just don't want to assume somebody's doing the reporting and not be done,
And then you grin on that child again and they're half dead.
or worse.
Yeah.
If any concerns, take up the food chain.
Unfortunately, I think all the things you talked about today are far more common than we would like to believe. I'd also say too, that you do have to be reasonable and be objective, because sometimes like, in my experience, the delay in care for a child, sometimes there are explanations for that. I mean, if you've had a toddler who limps around and cries a little bit, and then it turns out a day later they're still doing it, the parents take them to the hospital and it's a fracture. To me, that's kind of normal, because parents aren't going to run a toddler to the doctor every time they cry a little bit, because they cry all the time about everything. So, I mean, I think we can get overly strict as well, but they just apply common sense. Goes a long way.
And I'll say, especially at Children's, they will get social work involved and DHR involved for a lot of things that aren't abuse, that look like it could be abuse, but it's better to find out that it's not than miss it, I think. But, I mean, kids cry.
Yeah. I've heard a lot of the pediatricians talk about before, and I've heard this so many times in my career, that a toddler falling off of a couch has never really produced any significant injuries. And that seems to be a common story you get. And the kid will have fractures, bruises. Oh, they fell off the couch. They were playing and they fell off the couch. That should be a red flag.
That, and then the like 1 or 2 month old who fell off the couch, something, because they don't really move a lot.
Typically, law enforcement is dispatched when the child's involved. So if it's not just obvious, it wouldn't be a bad idea to mention to the law enforcement officer that, hey, it's a potential crime scene. And then they can do what they need to do on that end while you take care of the patient. This probably goes without being said, but food for thought.
Well, that is important, because they're dispatched here, but they're not dispatced with a lot of
Well,
things.
yeah, right. But I would make those suspicions known to the officer on duty. Yeah.
On the documentation side, remember the states changed the rules for documentation. It used to be 3 days. You have 1 day to finish your document. As we move forward, you're going to see that the hospital is going to let document when you get there. So make sure you're quick and efficient on that. I would have your review your document, especially in cases like this. Anything you write, you could see in court 1 day. So make sure you write things that make sense. If you use details, make sure those details are correct. If you got to use quotes, and then spell things correctly. So that it's not thrown up on a big screen 1 day and then see how you spell certain words and other words. Trust me. Speaking for a friend.
Tear you down.
Yes, sir.
All right, thanks for a great lecture. We didn't have any more questions come in online. So Dr. Ferg, we're in Opelika in 2 weeks, is that correct?
That's correct. We'll post that on Facebook. We got the address, chief. We've got the address.
Actually, I'll post that out later today.
Okay,
I want to make
perfect.
sure it's right. I'm not sure I've got the right address.
So that'll be posted today then?
Cool. Yeah.
All right.
And we'll look forward to seeing everybody then. Thank you for participating with us today. Everybody have a great day.